Welcome to the deep dive. We're here to, pull out the key insights from some pretty dense sources directly for you.
That's the plan.
And today, our focus is really sharp. We're looking at a hyperbaric medicine textbook.
Mm-hmm.
Our mission, basically, is to give you a concise, valuable overview tailored specifically if you're a hyperbaric or diving physician.
Exactly. Think of it as a shortcut, maybe, to understand what this book's really offering.
Yeah, and help you figure out if it's, worth adding to your shelf, worth your time.
Precisely. We've sort of sifted through what seems to be the core content, looking at chapter titles, the contributors,
Right.
to really bring you the key takeaways. We want to help you gauge how useful it might be, in your day-to-day practice.
Okay, so let's unpack this a bit.
Mm.
The textbook, it looks remarkably comprehensive, doesn't it?
It really does.
Just glancing at the chapter titles, you see a huge range.
Yeah.
Things like crush injuries, acute traumatic ischemias,
Yeah.
then hyperbaric oxygen for exceptional blood loss,
Hmm.
severe anemia, basically. Then it covered skin grafts, flaps, uh, radiation injury stuff.
Lots of radiation injury, yeah. Delayed effects, too, like in gynecologic cancers.
And there's one on adjunctive hyperbaric oxygen therapy. Looks like the title got cut off in our source, but it suggests even more application.
Right. It gives you a real feel for the breadth.
And what about the people who wrote it? That seems important.
Oh, definitely. What really stands out is the pedigree of the contributors. This
Okay.
isn't just one person's view. It's a collection of insights from MDs, PhDs.
Yeah.
There's even a U.S. Navy saturation diving officer listed.
Oh, interesting.
And, directors, professors from big medical institutions, organizations like UHMS, the Undersea, and Hyperbaric Medical Society.
So a lot of heavy hitters.
Exactly. That diverse expertise really lends significant weight and credibility to the information.
Okay, good to know. So with that kind of landscape in view, let's get into some specifics. Something every prescribing physician thinks about. Drug interactions.
Yeah.
How does hyperbaric oxygen maybe affect medications? Does the book cover pharmacokinetics?
It does, yeah. It addresses how hyperbaric oxygen could, theoretically, affect things like drug absorption, distribution, metabolism, elimination, the usual ADME stuff.
Right.
But what's actually quite reassuring is that the bulk of the evidence seems to suggest that for single-dose meds, acute HBO2 exposure, it generally doesn't change pharmacokinetics much.
Okay, so for the most part, if
Yeah.
you give a standard single dose around an HBO2 session, you probably don't need to rethink how that drug works in the body.
That seems to be the main takeaway. Your usual understanding likely holds for most common situations.
Good. Are there any exceptions flagged?
Well, yeah. The textbook does point out some interesting findings from rodent studies, specifically with barbiturates like thiopental, pentobarbital, phenobarbital.
Oh, okay.
These studies hinted at potential changes in sort of how long the drugs worked and maybe their potency, but under very specific hyperbaric conditions, sometimes involving nitrogen in the mix, too.
Nitrogen. Wow. Okay. That's a layer you don't often think about in standard clinical HBO2.
Exactly. And it also mentions the historical use of phenobarbital, actually, to prevent oxygen seizures.
Right.
And apparently no adverse effects were reported then. But the key takeaway, the practical point, is the recommendation for really vigilant respiratory monitoring if your patient is on barbiturates during HBO2.
Why is that?
Potential for increased CO2 retention in some people. So yeah, just keep a close eye.
Absolutely. Vigilance is always key.
Yeah.
Okay. Flipping the coin. What about contraindications or precautions? When should we maybe pause or be extra careful with HBO2?
This is critical, obviously, for safety. The textbook seems quite meticulous here. It lists conditions where the pressure changes themselves could be risky.
Like what? Ear stuff.
Exactly. Anything affecting ears and sinuses, acute URIs, otitis media, history of certain ear surgeries like mastoidectomy, stapedectomy, tympanoplasty.
Cochlear implants, too.
Yep, cochlear implants, total ossicular prostheses. The core issue is potential barotrauma or device problems from the pressure shifts.
Makes sense. And what about issues related to the high oxygen levels themselves?
Right. There are a few. Congenital spherocytosis, that's a red blood cell disorder. There's a theoretical risk of hemolysis, red cells breaking down from the high oxygen pressure.
Okay.
Another big one, chronic respiratory failure with hypercapnia, so high CO2 levels. In these patients, the high oxygen could actually suppress their drive to breathe.
A classic concern.
Definitely. And then there's claustrophobia, not physiological, but very real practically.
Of course.
And pneumothorax. Collapsed lung, that gets a nuanced
Oh,
discussion.
yes, the pneumothorax.
Yeah.
Always a big topic, especially in diving medicine, too. What's the guidance there?
It's pretty detailed. Attention pneumothorax, the kind that's getting worse and compressing things, that's an absolute no-go unless a chest tube is in place first.
Right.
For small asymptomatic ones, like less than 2 centimeters maybe observation with normal pressure oxygen. But the book apparently cautions this doesn't guarantee safety for later hyperbaric dives or treatments.
So, still risky.
Potentially, yeah. The most conservative path, especially for a recent spontaneous pneumothorax, is often delaying non-urgent HbO2 for maybe 6 weeks to let it fully resolve.
Okay. And for those chronic respiratory failure patients?
The key insight is just close monitoring for hypoventilation. And be prepared for potential issues like hemolysis or worsening anemia. You really need to know your patient's full picture.
Absolutely. That really highlights the need for thorough workups beforehand.
Yeah.
Okay, let's shift gears a bit to the practical side. How is HbO2 actually administered? What technical points does the book cover?
It gets into monitoring inside monoplace chambers, the single-person ones. It mentions using the AA ratio, the alveolar arterial oxygen tension ratio, to check lung function.
Okay.
And a key caution it flags is about treating patients who need more than 50% IO2, more than 50% oxygen at sea level.
Why is that?
Basically, unless the benefit clearly outweighs the risk, be very careful. The reason is their arterial oxygen level, the PO2, can be really unpredictable under hyperbaric conditions if they have severe lung issues.
Right, their response might not be what you expect.
Exactly. Unpredictable.
What other monitoring does it talk about? ICP, EEG.
Yeah, it outlines methods for monitoring intracranial pressure, ICP, and EEG in monoplace chambers. Usually needs special transducers, pass-through ports that keep the pressure sealed.
Right, specialized gear.
And it also highlights using transcutaneous oxygen measurements, PTCO2, measuring oxygen on the skin.
Ah, TCPO2s. Very common.
Very common, yeah. A non-invasive way to check tissue oxygenation before, during, after HbO2. Useful in multiplace and monoplace settings.
Good point. And what if your patient needs IV fluids or meds during the treatment? How do you manage that in a pressurized chamber?
It gives a pretty practical guide for monoplace chambers, talks about needing secure lure lock connections prevent leaks, obviously, one-way valves for flow direction, special pass-through ports in the chamber wall, external stopcocks for control, even high-pressure infusion pumps designed to work under pressure.
So it's feasible, but needs the right setup.
Definitely. It also touches on continuing things like TPN intravenous nutrition and insulin infusions during HbO2. Generally, the advice is keep them going to avoid metabolic problems like glucose swings or nutritional gaps.
But are there limitations?
Well, yeah. It does note that some older monoplace chambers, like the Seachrist 2500B model, might have limitations with their IV ports that can make treating really critically ill patients who need lots of complex infusions more difficult.
Okay, those are really crucial logistical points. They can definitely impact who you can treat and how. Let's pivot to, well, a foundational use of HbO2. Wound healing. What are the key mechanisms the book emphasizes?
The big message is that getting enough oxygen to the wound is absolutely critical for healing, paramount.
Makes sense.
It highlights this huge estimated increase, like 20-fold in metabolic activity and blood flow needed for tissue repair.
Well, 20-fold.
Yeah, and among ways to boost perfusion and oxygenation, HbO2 stands out because it offers sort of a double benefit. First, measuring TCPO2 near the wound can give you an objective clue about whether HbO2 might help, and even help predict if the wound will heal.
So a predictive tool.
Right. And second, HbO2 itself can directly crank up the tissue oxygen levels by like tenfold. That massive increase is really the core mechanism.
A tenfold increase. That's dramatic. What are the sort of tangible clinical effects of this mass effect of oxygen?
Clinically, that big oxygen boost is really helpful for compromised tissues. Think threatened skin flaps, grafts that are swollen.
Right.
Exactly. Or in severe stuff like crush injuries, compartment syndromes where blood flow is choked off and tissues are starving for oxygen.
Okay.
And the book distinguishes between the immediate kind of short-lived hyperoxygenation effect during the treatment and the longer-term benefits that build up with repeated treatments. Those secondary effects are things like promoting new blood vessel growth angiogenesis and reducing inflammation.
So it's not just a temporary fix.
Not just temporary. That even mentions Borema's classic Life Without Blood study, foundational work showing just how vital oxygen delivery is. Provides that historical context.
Interesting to see those roots. Does the book get into oxygen dosing? like pressure and time?
Oh, absolutely. It talks about the dose-response relationship. How much hyperoxygenation you get depends on the treatment pressure.
Right.
And it explains why higher initial pressures are used for specific things like CO poisoning or gas gangrene, where you need rapid, massive oxygen delivery right away.
Makes sense.
But, and this is a crucial point it makes, HBO2 only works if there's adequate blood flow to the tissue. If perfusion is totally gone, the extra oxygen in the blood just can't get where it needs to go.
So circulation is still king.
Circulation is still king. Optimizing that remains goal number one.
That's a critical reminder. HBO2 is often an adjunct, right?
Yeah.
Not magic on its own. Okay, let's focus on some specific applications that our audience, hyperbaric, diving docs, see a lot. Crush injuries, traumatic ischemias.
Right. For those severe injuries, the book explains how the initial damage causes both hypoxia, lack of oxygen, and edema swelling. And unfortunately, these feed each other, creating a vicious cycle that worsens blood flow and oxygen delivery.
A downward spiral.
Exactly. HBO2 jumps in multiple ways. It causes vasoconstriction, narrowing blood vessels, which sounds bad, but actually helps reduce the swelling, the edema.
Interesting paradox.
It is. And importantly, it keeps oxygen delivery going even when blood flow is reduced. And finally, it supplies enough extra oxygen to support the body's own healing and infection-fighting processes.
So it's hitting that cycle from several angles.
Actively disrupting it.
Okay. What about skin grafts and flaps?
Yeah.
A common reason we use HBO2 trying to salvage tissue.
Yeah, the textbook highlights positive results from animal models showing HBO2 improved flap survival rates.
Good.
It also suggests a really important potential role in irradiated tissue, which is notoriously hard to heal. By boosting blood supply there, HBO2 might improve mucosal coverage, reduce wound breakdown risk in things like osteoradionecrosis bone damage from radiation.
Okay.
And it talks about using it both before and after surgery, like reduction mammoplasty in women who've had prior breast radiation, trying to optimize tissue health.
Right. Prepping the tissue bed. Now, let's broaden that to radiation injury in general.
Yeah.
It's complex, delayed effects.
Very complex. The book explains this oxygen gradient phenomenon, basically how oxygen levels normally guide wound healing, promoting new blood vessels, angiogenesis, and fibrous tissue, fibroplasia. But radiated tissue is different. It's got poor blood supply. It's chronically hypoxic.
Right.
So the book details the well-known 2010 HBO2 protocol, typically 20 treatments before surgery, 10 after.
The Marks protocol, essentially.
Essentially, yeah. And it highlights its really significant impact on success rates for jawbone reconstruction in radiated tissue.
What ways?
Things like restoring bone continuity, getting enough bone height and width for dental implants, keeping the arch form, facial contours, plus reducing wound breakdown and infection rates. It's a cornerstone application.
Definitely a key use. What about osteoradionecrosis itself, or RN?
The book stresses the modern view. ORAN isn't primarily an infection, like the old thinking. It's more a chronic healing defect caused by radiation damaging the blood vessels.
A vascular issue at its core.
Exactly. It outlines the 3 clinical stages of ORAN in the jaws and really pushes for a combined approach. Aggressive surgical debridement, getting rid of the dead bone alongside HBO2.
Makes sense. Surgery plus oxygen.
Right. And it also briefly mentions good evidence for HBO2 in radiation proctitis, rectal inflammation post-radiation. Cites randomized trials supporting a level A recommendation.
Strong evidence there.
Yeah. And also notes smaller pilot studies suggesting benefits for radiation cystitis bladder inflammation.
Okay. What about burns? HBO2 often comes up there, too.
The clinical observations summarized in the book seem quite positive. They point to things like faster healing, shorter hospital stays, lower mortality.
Reduced fluid needs, too.
Reduced fluid needs, fewer surgeries. It mentions one large series reporting a significant drop in mortality with HBO2.
Wow.
And it highlights the potential for pretty significant cost savings because of these better outcomes.
That's always relevant. Okay, let's turn to diabetic foot ulcers.
Yeah.
DFUs. Hugely prevalent, often really challenging for our listeners.
Absolutely. The textbook positions HBO2 as tackling that critical ischemia hypoxia part of the troublesome triad in DFUs, neuropathy, ischemia, infection.
Right.
It describes the typical healing stages you might see with adjunctive HBO2. Sometimes an initial phase where it looks like it might be getting worse.
Counterintuitive.
A bit, yeah. Followed by a latency period, then angiogenesis, new blood vessels, and finally epithelialization, new skin growth. It mentions the Long Beach Wound Score, LBWS, as a tool to quantify improvement. And it references guidelines generally backing HBO2 for more severe ulcers, like Wagner grade 3 or higher, after good debridement, or if standard care hasn't worked after about 30 days.
What about less severe ulcers, Wagner 1 or 2?
There, it notes the evidence is less conclusive currently.
And the importance of getting the basics right first. The voids criteria.
Oh, absolutely. The textbook reinforces voids, vascular assessment, offloading, infection control, diabetes control, surgical debridement as fundamental best practices before you even consider HbO2 for DFUs.
Got it. Prerequisites.
Yes. It also discusses using TCPO2 measurements to predict who might respond best to HbO2. Certain oxygen levels measured inside the chamber seem to correlate with healing likelihood.
Useful for patient selection.
Potentially, yeah. And it summarizes some recent randomized trials on Wagner 1 and 2 ulcers. The results seem a bit mixed regarding amputation rates, and it stresses that you really need to consider the specifics of the ulcer, how acute it is, the setting when looking at those study outcomes.
Nuance is key. Okay, how about osteomyelitis? Deep bone infection. Tough to treat, especially with diabetes or poor circulation.
Right. The book explains that osteomyelitic bone typically has very low oxygen levels.
Makes sense.
And it details how HbO2 effectively boosts oxygen within the bone, citing preclinical work. This increased oxygen helps the body clear residual infection after debridement.
And antibiotics?
Crucially, yes. It enhances the activity of certain antibiotics that struggle in low oxygen environments. It names names. Aminoglycosides like tobramycin, vancomycin, quinolones, TMP-SMX, nitrofurantoin.
That's a significant benefit.
It really is. It summarizes clinical studies showing better outcomes with added HbO2 for osteo fewer relapses, lower amputation rates, more healing.
Okay.
It even touches on using things like wellness and goal scores to help decide between salvage and amputation in complex non-union cases. And mentions saucerization, a debridement technique often paired with long HbO2 courses, maybe 60 treatments, for refractory cases.
60 treatments, wow.
Yeah, for the really tough ones. And notes potential benefit for chronic refractory osteo in the spine, too.
Good to know. Necrotizing soft tissue infections, less common, thankfully, but devastating. What's the book say?
It describes the mix of bugs usually involved anaerobes, aerobes, and stresses how local tissue hypoxia drives the infection. Mentions the Amsterdam classification.
Okay.
Now, it acknowledges a Cochrane review found no definitive high-quality trials.
Right, the RCT issue.
Exactly. But it does highlight a logistic regression analysis from one study suggesting a strong link between adding HbO2 and better survival.
So suggestive evidence, if not level 1.
Suggestive, yeah. Potential benefits discussed include less tissue loss, fewer amputations, and lower mortality.
Worth considering in those dire situations. We saw a chapter listed on exceptional blood loss, anemia. Anything specific there in our materials? Critical care relevance?
You know, it's interesting. Despite that chapter title, the excerpts we reviewed didn't actually provide specific details on using HbO2 for severe anemia or massive blood loss. So we can acknowledge the topic is likely in the book, but we can't really comment on the specifics based on what we have here.
Fair enough. Shows the breadth, even with source limitations. Traumatic brain injury, TBI, always a hot topic for HbO2 research.
Yeah. The book summarizes studies looking at HbO2's effects on things like intracranial pressure, ICP, PaO2, brain metabolism, and TBI.
Oh, they find.
Well, observations of ICP decreasing during pressurization and potential for HbO2 to improve cerebral oxidative metabolism not just during the treatment but for days after suggests it might act as a signal transducer, influencing cell processes.
Interesting mechanism.
And importantly, it mentions a prospective randomized trial by Roxwald and colleagues showing better functional outcomes in severe TBI patients who got HbO2 plus normobaric hyperoxia versus standard care.
Promising results there. Anything else mentioned briefly, other applications?
Yeah, just quick mentions, historical studies on Hansen's disease, leprosy.
Really?
And, of course, it acknowledges decompression sickness, DCI, as a standard indication for hyperbaric chambers, though this book seems more focused on the medical uses of HbO2.
Right, not primarily a diving medicine text.
Whoa.
Okay, wow, that really covers a lot of ground. Seems like a very thorough overview of what's likely in this textbook. So let's bring it back home for our listener, the hyperbaric or diving physician. Based on this deep dive, is this book something they should seriously consider?
I'd say absolutely. It really presents itself as a potentially valuable, comprehensive resource for professionals right in our field.
Yeah.
It seems to offer that wide range from the basic science underpinning HbO2 through to detailed clinical applications and the technical, practical aspects of administration. That seems particularly useful for day-to-day work.
So a good all-rounder.
Seems like it. If you're looking for a well-rounded, authoritative guide, this appears to fit that description quite well.
And the fact it's not just one author, but this collection of experts.
Yeah.
That adds real weight, doesn't it?
Precisely. That diverse expertise from leaders in the field, from UHMS connections, it lends significant authority.
So whether you're, seasoned in hyperbarics and want an up-to-date reference, or maybe newer to the field needing a solid foundation.
Exactly. Either way, the breadth of topics, the apparent depth supported by research and expert opinion, it looked like a really worthwhile resource to consider adding to your library.
Okay, so what does this all mean for you listening in?
Well, it means that hyperbaric medicine is constantly evolving, doesn't it?
It really is.
And staying on top of the research, the best practices, the protocols.
Mm-hmm.
It's just crucial for giving your patients the best care.
Mm-hmm.
And having access to a comprehensive, respected resource like this textbook could be a really significant help in that ongoing professional journey.
Which brings us to maybe a final thought for you to consider. Reflecting on the specific types of patients you see most often, the clinical challenges you face. Which of these applications we discussed today really struck a chord?
Yeah, what resonated? Maybe digging into those specific chapters in the textbook could be a really valuable next step for you, enhancing your knowledge, maybe refining how you approach patient care in those areas. Food for thought.